when I started to attend hepatology meetings about 14 years ago, I think 2009 was the first EASL that I attended, 8 or 9. I was surprised by the fact that Switzerland, although being a rather relatively small country in the world of hepatology, has brought along an incredible number of very, very well-known, internationally respected hepatologists. So hepatology, the liver, has been very strong in Switzerland. And one of the most eminent, prominent, and most dear colleagues in Swiss hepatology for many years and decades has been Darius Morapour. He received his MD here in Zurich. He trained here in Zurich. Then he went as a postdoctoral fellow to Mass General Hospital at Harvard Medical School, came back from the United States, short visit or, sometime visit in Germany at the University Hospital in Freiburg, then returning to Switzerland, focusing on viral hepatitis, particularly hepatitis C, and became then, after a time as a visiting professor at Rockefeller University, first chief of hepatology and now head of the GI department in Lausanne. He's currently one of the eminent figures in Switzerland still dealing with hepatitis C and hepatitis E. The one that is coming now, as hepatitis C is seems to be a manageable disease and has a lot of very interesting aspects. He's been funded by the Swiss National Science Foundation for many, many years. He's currently associate editor of Hepatology. He served as an associate editor for the Journal of Hepatology and is on the board of the Journal of Virology. He was our president of the Swiss Society for the Study of the Liver for many years and is still on the governing board of the European Association. And I'm very, very happy that Darius has agreed to take a peek with us into the future of hepatology, which is going to be a very exciting one. Thank you.
Thank you so much, Joachim. Well, it's a real challenge to speak at the end of such an amazing day, and especially after Santiago Calatrava, who took us on a journey that allowed us to dream for a half an hour. It was absolutely incredible. And to speak after so many eminent colleagues and dear friends. Last but not least, it's a challenge to speak on this topic that you gave me, and I decided to modify it slightly and to reflect on where hepatology was when the Gastrozentrum was founded, to illustrate some aspects of where we are today and maybe allow a little perspective on where it might be tomorrow. I have two disclosures to make. The first disclosure is that I have a special relationship to this hospital, as I spent the first days of my life here. The second disclosure is that many of you are dear friends and colleagues for many years, and I would like to acknowledge especially Josef Altdorfer. Josef really encouraged me to write one of my first papers. It's still being cited very regularly, and I have to say not only Josef, but also Philipp, who is in the room, Andy, Bernhard, Stefan, all of you, Joachim, and the new power generation, Stefan, Jonas, Katrin, have been friends and dear, dear colleagues for many years. Now, you asked me whether we are all going to die of liver disease. I don't think so. These are the 10 biggest threats to global health as WHO has defined them 3 years ago. So where were we in hepatology in 1992? We had some treatment. We had diuretics, we had lactulose, we had corticosteroids, we had UDCA, but no one believed in UDCA. It was only in the years around 2000, 2005, when the first follow-up data became available of 10 years of follow-up of PBC patients that were treated at early stages, where people started to believe that it actually does something. We had the vaccine against hepatitis B, and that was probably one of the major breakthroughs. And the Hep A vaccine was just approved a year earlier. Today, we have DAAs, we have progress in surgery, in interventional radiology, we have systemic treatments for HCC, we have siRNA-based treatment for rare liver diseases. So we've come quite a way. At the time, molecular biology just began to enter clinical medicine. PCR was invented a few years earlier. Today, it's part of our daily practice, not only in diagnostics, but also in clinical care. The genetic basis for most hereditary liver diseases was yet to be elucidated. Wilson disease, the gene was cloned a year later, and hemochromatosis, it was 96. And all the other rare diseases had yet to be discovered. HCV had just been discovered, but no one would think what kind of a wave of disease and of death we would see in the subsequent years. HEV had just been cloned in 1990, but it was believed to be something that is far away. Liver transplantation started to take off in the mid-1980s, but just think that at that time, replicative hepatitis B and hepatocellular carcinoma were considered contraindications to liver transplantation. Today, we do not need to transplant patients with hepatitis B anymore, unless they develop liver cancer. And HCC, we know the criteria that would allow us to bring a patient to transplant successfully, and we even have means to downstage the disease in patients who are beyond criteria. HCC in general was believed to be rare in the West. By today, the incidence has at least doubled, and predictions are that it will increase 40 to 50% more in the years to come. The first TIPS has been performed in 1988 by Martin Rössle in Freiburg im Breisgau, but it was still an imperfect procedure. It was improved only in the beginning of the 1990s, and it is now a mainstay of the management of portal hypertension in all tertiary centers. And finally, Ludwig had coined the term NASH, but no one had noticed until the 1990s, when Elizabeth Powell showed for the first time that people with NASH can actually evolve to cirrhosis, complications, and liver cancer. So I decided to take 3 examples of progress in this area. And of course, since I'm a viral hepatitis aficionado, I chose 2 viral hepatitis topics, and to do justice to the title that Joachim and Bernhard kindly assigned to me, I also have to speak about NAFLD. So Hep C is really a success story of modern medicine, and I think that all of us who have been able to work in gastroenterology and hepatology for the last 20 years have been blessed to live with this. Harvey Alter, Mike Houghton, and Charlie Rice are outstanding scientists. They were awarded with the Nobel Prize for Medicine in 2020. They were awarded for the discovery of the hepatitis C virus. And what did this do? Just think that in the 1980s, and surgery was not as elaborated as it is today, with each unit of blood transfused, you had a 1% chance of acquiring post-transfusion hepatitis. Surgery that today does not need blood transfusion anymore, at the time sometimes required 10 units of blood transfused. So at the end you had a 10% chance of having Hep C, and you wouldn't notice. You wouldn't notice for 10, 20, 30 years until you develop complications. Anti-HCV screening by serology was introduced in 1990-92. It was in 92 where we had reliable second-generation serologic assays, and subsequently also nucleic acid-based testing, and today post-transfusion hepatitis C is virtually eliminated. In terms of therapy, over these 25 years, we went from very difficult to tolerate treatment with a 10 to 15 to 20% success rate to cure in almost all patients with easy to take oral combination treatments. So for Hep C, developments went from the discovery of a viral agent in 1989 to cure in 2014 within 25 years. And this is reminiscent of a Swiss endeavor that took place around the same time. And this is the Gotthard-based tunnel. In the Gotthard-based tunnel, the 57 kilometers between Erstfeld and Bodio were surmounted during the same period. And the success to the Gotthard-based tunnel were, of course, the big breakthroughs. But more important were the intermediary attack points, the Zwischenangriffspunkte. And the same is true for Hep C. In Hep C, the Zwischenangriffspunkte were the successive development of model systems that allowed us to study the virus in vitro, to develop antivirals, and to evaluate them in reliable systems. And the most important development here was the establishment of a replicon system in 1990 by Ralf Bartenschlager and colleagues. If there would have been a fourth place for the Nobel Prize, I'm sure that Ralf would have gotten this one. This progress allowed now a very deep understanding of the viral life cycle, and it also allowed to identify targets for antiviral intervention, including protease inhibitors, polymerase inhibitors, and NS5A inhibitors. And these can now be combined into single tablets that would cure our patients within 8 to 12 weeks. So this is huge progress. And with this, the monster of hepatitis C was brought to his knees, but he's not finished off yet. Indeed, hepatitis C is down, but it is not out. If you see the latest epidemiological data on hepatitis C virus infection, the overall worldwide prevalence of viremic patients has decreased a little bit, from around 63 million to 56 million in the last 5 years. It's important to note that yes, around 7 million patients were cured over these 5 years, but virtually the same number of new infections occurred, and what we see here as a decrease is actually the 5 to 6 million people who died over that period. You see also that there are countries who have done an outstanding job in treating Hep C. This is first and foremost Egypt, where the infection was very, very prevalent in the population. But others, just look at China, Pakistan, India, Russia, they still need to do a huge, huge effort. So there are major challenges in Hep C on the clinical side in terms of diagnosis, access to care, in the translational arena, especially in terms of vaccine development, but also in basic research. The hepatitis C virus, as many viruses, has been one of the best teachers of cell biology and of immunology, and it continues to be an outstanding and amazing model of a virus that is capable of establishing chronic infection in an immunocompetent host. And so I think that further progress in all these areas is truly needed. Now, despite this, interest in Hep C research has undeniably decreased over the last years, and Hep C's place has been taken over by NAFLD. So what is NAFLD? Non-alcoholic fatty liver disease, for those of you who are not in hepatology, is an umbrella term. It means that the liver is fat, and it may be inflamed, it may be cirrhotic, and there may be a hepatocellular carcinoma. Non-alcoholic fatty liver is probably the benign situation, non-alcoholic steatohepatitis, is the situation where inflammation occurs and where the disease can be progressive. The diagnosis includes that the histological features are basically, not completely, but basically indistinguishable from those seen in alcoholic liver disease. This is the definition by Ludwig, coined in 1980, and that there is no significant alcohol consumption. So what is a significant alcohol consumption? This is very controversial. EASL has defined a cutoff of 30 grams per day for men and 20 for women. ASLD allows a little bit more, but the more recent guidelines, including the German guideline, is more restrictive, and I believe they are right to be more restrictive, saying that for men it should be 20 grams, which is a little glass of wine, and for women 10 grams per day. It's also, in clinical practice, important to exclude other liver diseases, especially viral hepatitis, alpha-1, hemochromatosis, sometimes autoimmune liver disease, and especially in lean patients, to exclude secondary forms, such as Wilson disease. A new definition, and this is the one that you proposed in the title that you gave me, is MAFLD, Metabolic Dysfunction-Associated Liver Disease. Here you see the principle. You have a fatty liver, more than 5% fat infiltration in the liver. This can be seen by ultrasound, by CAP or other non-invasive tools, or in a histology. And then you have either overweight or obesity, that is a BMI above 25 or 30. You have a lean person, normal weight, with at least 2 of the metabolic conditions, they are listed here, or you have type 2 diabetes. So this is very good because it's now a positive criteria-based nomenclature. However, I personally believe that this is premature. Premature for several reasons, one being that we lose the term NASH. There is no MASH. The second thing is that I personally believe that our pathogenetic understanding of NAFLD is really in its infancy. And what we will need in the future, also for new therapies, is an understanding that is based on pathogenesis, on genetics, and other parameters. And this will have to somehow be reflected in a new name. So I personally, for the moment being, I prefer the term NAFLD and NASH. So this is clearly becoming a major problem. Here in red on the left, you see Hep C as an indication to liver transplantation. It is decreasing very, very swiftly. And the only other indication that is increasing very much in green is NASH. So this is clearly taking over. And the basis for this is the epidemic of overweight and obesity. These are trends in BMI in 200 countries worldwide over, you see here, 40 years. And it is striking to see that in men and in women, there is a huge increase, not only in high-income English-speaking countries, but also, for instance, in Latin America, in Asia, in the Middle East, and in North Africa. It's particularly striking in the United States. These are projections until 2030 for persons having on the left a BMI over 30 and in the right column over 35. The projection is that 50% of the American population will have a BMI over 30 by 2030. And what is very striking for me is to see the correlation with demographic parameters and with socioeconomic and educational status. Here are the correlations with mean household income. And you can see that the lower the mean household income, the higher is the prevalence of obesity. The same is true in Switzerland. Overweight and obesity in Switzerland increase continuously. Today, 12% of men and 10% of women are obese. And in Switzerland as well, there is a gradient in terms of different parameters, including education. And the gradient is particularly steep, as you can see here, in women. So I think we need to take this into consideration in our efforts to try to educate and to help and to correct this trend. Now, what is also worrisome is that not only overweight and obesity are increasing, but alcohol consumption is also increasing. These are trends in different areas of the world, and you can see that globally, the prevalence of drinkers and of heavy episodic drinkers is increasing. And it's the same in many areas of the world. And the two things often coexist. There is a nice study that was published recently by Katharina Stauffer and colleagues from Vienna that shows that 29% of patients that were presumed to have NAFLD, when you look for alcohol metabolites in their hair or in their urine, actually have a problematic alcohol consumption, at least moderate or excessive alcohol consumption. So we have a perfect storm. For Switzerland, Nicolas Gossens and colleagues have done a projection to 2030. And it's believed that by 2030, over 2 million Swiss people will have NAFLD and around 500,000 will have NASH. The problem is, if you look at physicians in Switzerland, there are currently a bit more than 600 gastroenterologists and only 37 that have a subspecialty title in hepatology. And for endocrinology, it's around 250. If you make the calculations, it would mean that every gastroenterologist in Switzerland by 2030 will have to take care for at least 50 cirrhotics with NASH, which clearly is not possible. We're all very busy with other things. So we need to select patients, and we need to team up with other specialties and with primary care providers. This can be done by different means. So to identify persons with NASH, and especially with NASH that has advanced fibrosis in the general population and in different persons at risk. Here the blue box is patients with type 2 diabetes mellitus. And there are currently different care pathways that are being developed. One starts with a simple blood test, a FIT4 test, for example. One starts with transaminases. One starts with an ultrasound or other means to detect steatotic liver. In the end, what is important is that there must be some way to select patients that need specialized care. This is also important in terms of management, because there are interventions that primary care physicians, endocrinologists, dietitians, and many others have to take care of. You see them here in the low-risk group. And on the other end, there are interventions that gastroenterologists and hepatologists need to take care of. And they are in the right column in the high-risk group. So in the spectrum of liver steatosis, NASH, cirrhosis, and liver cancer, I think that the job needs to be divided between primary care providers, different specialists, and then specialized care once a patient needs truly our interventions in terms of HCC surveillance, esophageal varices screening, the management of portal hypertension, and eventually, if necessary, the evaluation for liver transplantation. NAFLD-NASH is an area of currently very active pharmacological development. And it's amazing to see what is currently being tried in that arena. And it sometimes is quite pleiotropic. As a viral hepatitis aficionado, where you have a clear target and a clearly measurable outcome. Viremia is so simple. This, to me, sometimes looks like Star Wars, but it's early days. And it should remind us that actually what the most important measure is lifestyle change and lifestyle interventions. And so this, I believe, we should all encourage at all levels. Healthy food, we should render healthy food accessible and affordable for all. We should advocate it. The Mediterranean diet is an excellent example of good food. I hope, Diana, that you will agree. It's anyhow the best. Physical activity and avoidance of processed or ultra-processed food, especially sugar-rich or fructose-rich food. Now this allows me to open a little chapter, and I will be brief on this. It's our favorite pet today, is hepatitis E, because it has to do with nutrition. In Lausanne, we started a multidisciplinary research effort in diagnostics, in basic research, and in clinical research on hepatitis E around 10 years ago. Why? Well, because hepatitis E is now the most common cause of acute viral hepatitis in the world, including in Europe and in Switzerland. There are two scenarios. Genotype 1 and 2 infections are transmitted from humans to humans in areas of the world that have limited sanitary and alimentary hygienic resources. These two genotypes infect around 20 million people every year and claim 70,000 lives, often pregnant women. What we did not know at the time, this we know since about 15 years, is there are two other genotypes. These are genotypes 3 and 4, which are zoonotic infections that are transmitted from certain animals through humans, through the consumption, especially of raw or undercooked meat, with zero prevalence rates that are much higher than we previously thought. Up to 86% of blood donors in south of France had contact with this virus. And what we also didn't know at the time, we know this since around 10 years now, is that especially HEV genotype 3 can cause neurologic complications, it can trigger acute and chronic liver failure, and it can persist in immunocompromised patients, leading to cirrhosis, liver failure. Here are the genotypes, 1 and 2, found only in humans so far, 3 found in different animal species, especially the domestic pork, but also some wild animals and humans. Genotype 4, same, found especially in China and Southeast Asia, but also in Europe and also in Switzerland. And then there are some more special viruses, the rabbit hepatitis E virus that we also have in Switzerland, the dromedar hepatitis E virus in the Middle East, and more recently, a very distant member of the Hepaviridae family, the rat hepatitis E virus that has been found to infect humans, first in Hong Kong, then in Toronto, and now also in Europe, in Spain. The underlying problem that we have and that explains this situation is the high prevalence of hepatitis E virus in the domestic pork. And of course, this ends up in the food chain. This is a review article that has looked at PCR positivity for HEV RNA in sausages bought in retail stores in different European countries and in China. And you can see here that all of the countries have a high prevalence of HEV RNA in pork meat, especially pork liver derived food products, up to 70%, as you can see here, in the liverwurst bought in the Netherlands. So we were interested in the lab to see what kind of viruses circulate in Switzerland. And so from the first a bit more than 100 cases that we've diagnosed at the CHUV, we've done subtyping analyses. And what is striking to see here is that the majority of viruses belong to a specific subtype. And this specific subtype has so far been found only in Switzerland. It has been around the same time or a bit earlier discovered by Claudia Bachhofen in Zurich, actually by Thomas Bock and then Claudia Bachhofen, in a fattening pig, in a raw pork liver sausage, and in one patient. And it's the same thing. In the meanwhile, we have expanded our analyses also by the use of next generation sequencing. And what we see now is that more than 80% of the infections that we see in Switzerland are due to this exact same subtype, which the International Committee for the Taxonomy of Viruses has now put to 3H. But if you take classic 3H, which has been found only in some patients in France so far, is clearly distinct from the Swiss 3H, the 3HS. It forms a different cluster. It's unfortunately just below the cutoff that would allow it to be named an individual subtype. Claudia Bachhofen also went on and looked at porks and wild boars as well as meat products in Switzerland, and she found exactly the same thing. So we have the same virus from stable to table to the patient in Switzerland. And so the question is, why? Why is that so? Well, if you look at Switzerland, with its beautiful geography, it has natural boundaries. It has big lakes and it has mountains. But this does not suffice as a reason. If you want to really understand the reason, you need to study literature that you're not used to study. This is the annual report of the Swiss Meat Producer Association. And if you run through the tables, you'll be amazed to see that for pork meat, everything that is produced in Switzerland is consumed in Switzerland, and there's hardly any import or export of pork meat. So Switzerland is a small country in the middle of Europe that has its own vivarium of porks, but also of hepatitis E virus. Now, this, of course, offers wonderful opportunities for research. We have recently launched a big full genome screen in patients to try and identify the determinants for severe outcomes of hepatitis E. Because we have a totally homogeneous virus population, so if we see a signal, it must be something that is in the host and not in the virus. But it also offers opportunities for intervention. And the wonderful example is Ticino. Ticino, until 5, 6, 7 years ago, was really the hotspot of hepatitis E in Switzerland. 1/3 of the population in Ticino has had contact with this virus. And this is due, among others, to specialties that are very much liked in the Ticino. One is the mortadella di fegato cruda, which of course the amateurs like to eat raw. Since this was known, the government in the Canton Ticino issued rules, and since January 2017, the pork liver has to either be cooked to be used in a sausage, or you have to use liver from veal or from beef. And see what this has done to the incidence in gray of hepatitis E in Ticino. In Ticino, they almost do not see any hepatitis E anymore. So nutrition is important in many aspects. So let me please finish by a few thoughts about hepatology tomorrow. Of course, in that context, one likes to cite American baseball legend Yogi Berra. One of the nice things he said, he said many, many nice things, is the future ain't what it used to be. So what I think we are going to see tomorrow in hepatology is the implementation of personalized or precision medicine in NASH, but also in liver cancer, as we have it today in viral hepatitis. There are going to be tremendous further advances in stem cell biology, in sequencing and large-scale omics technologies, in nanomedicine and imaging. And these will allow for novel cell-based therapies and delivery systems, diagnostic tools, for example, liquid biopsies, a better understanding of our microbiota and the connection to liver disease and liver disease management, as well as scaffolds for tissue support and repair. Maybe in 30 years, if we can meet again, we will do much less liver transplants because we have smart tools to replace a liver temporarily or definitely. We'll see. Future generations of hepatologists will have to know how to integrate, and they will have to be assisted in integrating big data to prevent, diagnose, and treat liver disease. I firmly believe that distinctive skill sets, technical skill sets, will be important also for hepatologists and will offer new opportunities for the management of patients with liver disease. So the close connection of gastroenterology and hepatology will be important. Just think of EUS-guided liver biopsies. Think of everything that can now be done in terms of vascular interventions together with interventional radiology and others. I think that a challenge will be to facilitate subspecialization in hepatology while maintaining a strong unity of the discipline. Just think of transplant hepatology or NAFLD-NASH hepatology, viral hepatology, autoimmune diseases. Further subspecialization will be necessary, but hepatology should nevertheless remain visible as a discipline. I think that hepatologists need to be more involved in public health issues, in education, and in advocacy. You've seen it for NAFLD-NASH, the way our food is processed and consumed, and how it is accessible for many. I think this is important. Patient empowerment will increase, especially through the use of mobile technologies. There are now smart applications that allow to monitor from a distance and continuously cirrhotic patients for weight gain, for hepatic encephalopathy, and for others. And I think that integrating these new tools into our practice will be very important. More general, I think that despite all the progress and the sophisticated data sets that we'll have, integrating thoughtful human care, including, and this is dear to me, palliative care, will be very important. We're still in our infancy in terms of palliative care in gastroenterology and hepatology. Pain management, nausea management are so difficult, and we still need to learn much more from our colleagues in this area. But I firmly believe that hepatology will continue to attract young talents. We need them as a highly varied discipline that closely integrates research and multidisciplinary collaboration. With this, I would like to thank you and wish the Gastrozentrum a very, very happy birthday. And I would also like to invite you to come to Lausanne and visit us. It would always be a great pleasure to welcome you and host you at Lake Geneva. Thank you very much.
Thank you. Thank you very much, Darius, for, I can say, just another absolutely outstanding, wonderful presentation in hepatology. Thank you so much.